Hello, old friends.
Hello. All right, so we've got the attendees slowly trickling in. I think let's give it a few more minutes and then we can smash
you'll
it
be
out.
paid for a while.
Sounds good. That's my tie. Is my tie straight? Oh, it's okay. It's good enough.
Okay.
It's okay.
Ever so slightly to my right, so.
It is a little bit. I think that gives it character, right?
Yeah. I mean, you know,
So,
back in
so what year are you guys?
I'm in 4th year.
Awesome.
I'm first year.
I'm in third.
Nice. Sorry, say again?
I'm in third year.
Third year, cool. So, Priyanka, what possesses someone in first year to join a surgical society? I was like,
Well, I'm so fascinated by surgery and everything about it. I think absolutely, it's honestly, it blows my mind. And I really do hope to specialize in surgery one day. So I thought of, broadening my horizons as much as possible from as early as possible. So yeah.
That's awesome. I wish I was as dedicated as you are. I was a horrible first year student. I was out. I was not doing what I was supposed to do. No, so I admire it. I mean, all you guys here at 6 o'clock on a Tuesday, just you'd never have caught me dead at 6 o'clock on a Tuesday for anything medicine related. No, it's cool. It's really
I
cool.
think this is one of the few things that's really like drawing people during the pandemic, because we've got to find something to keep us excited. We can't just study all the time.
Yeah. And I think what's really nice, like being able to interact with people of different years and stuff, like in the name, it's a society, right? Because I think that's something that's lacking in med school, is this kind of, there's no real social aspect to it, like you kind of, well back, when I was a student, at least, it was, you'd kind of have your group of friends and stuff, but compared to the student experience so many other degrees experienced, I thought we were quite lacking.
Yeah, I can actually agree with that. I think that we aren't as social as some of the other universities, and I don't know, in my class maybe a bit, we're still quite competitive, even though we really shouldn't be. We should be lifting ourselves up rather than trying to hide the past paper from each other.
So I've got good news for you and bad news. The good news is that it's not just your class specifically, but the bad news is that it doesn't stop. Like when you're doing medical officer, registrar, whatever time, it literally just carries on. There's almost this thought that people think there's only maybe 500% to go around, and if they help you and you get more percent, it means they get less, which obviously is not the case. Like, everyone can get 80, like.
Yeah, no, exactly. And I don't really understand how that translates like MO or reg time, because it really just comes down to whatever accolades you have behind your name and yourself in the interview and whatever courses you've done, kind of a vibe. Like,
yeah, but you'll see people, because the person come and kind of become competitive, people will keep quiet about if there's like an extra tat, or when the time comes for exams, they'll keep quiet about past papers or advice they've gotten from other people, or resource material. So it's terrible, but hey, you know what? If it's ever gonna change, we're the ones who are gonna change it, right?
yeah, 100%. Like, and this society specifically, like, there was a theme last year where it was focused on changing the face of medicine, and I actually think that expands into changing the culture of medicine as well, into being a more supportive environment, and not just medicine being the typical white old man doctor. Medicine is evolving, it's changing, and I'm very proud of our society for pushing that agenda forward. And last year's president that actually came up with that idea, she's joined the webinar, so I hope she's listening, and I'm giving her a shout out, Tatenda.
Yeah, no, I really hope so too. I think it's such an important message, but I think it's probably people in general. It's, you know, society and capitalism and whatever else, more than just medicine. Maybe it's a bit more concentrated in medicine, but we just stopped caring about each other. We started kind of trying to win our rat race, and that's where we are.
Yeah, no, exactly. I think we'll give it maybe 2 more minutes, and then I think we can start. And those who have joined us, I hope they enjoy.
That's awesome. Oh wow, I see a little thing saying this is live on YouTube as well. Oh, that's nice.
Yeah. Completely.
At least we're on a solid 63 here.
Yeah, no, I'm actually impressed with that much because, you know, no matter how many people RSVP, you never actually know how many will show up.
Exactly. It's like a birthday party, really.
Yeah, no. Once the parents stop curating the guest list, it's really a who come and go, who's gonna show up situation.
That's exactly it.
Well, why Barra? I'm curious. Everyone has a different reason.
There's two reasons. The first one was I was a student and there was a minibus accident, and they brought in all of these like really sick patients, and I think about 5 of them needed chest drains. And these guys went like a pack of wolves in there, the interns and medical officers and rages at the time. They went in, they closed the doors behind them, and about 10 minutes later they came out and all the patients had chest drains. And I was like, wow, that is insane. So that was one. The other part of it, the honest truth is I was a student and I dated an intern who was at Barra, and so kind of got the lay of the land. I'm just being honest, it is what it is.
We appreciate honesty.
Yeah, so I kind of then I kind of knew this. It just felt more like home because I had spent time there, you know, obviously visiting and whatever. Then Barra it was.
Yeah. Oh, that's very interesting. So I think I'm actually going to kick us off, and we can start. So
Let's do it.
good evening, everyone. It's my privilege to welcome you all tonight to the final lecture series and event of this year of 2020. And it is my distinct honor to welcome Dr. Joda. Dr. Joda graduated from Vert University in 2012, where he went on to complete his internship at Chris Hani Baragwanath Academic Hospital. He has attained courses in advanced trauma life support, advanced cardiac life support, advanced pediatric life support, neonatal resuscitation, and basic orthopedic skills, to name but a few. Dr. Joda has worked in the fields of pediatric surgery, trauma and trauma ICU, emergency medicine, and even emergent air flights for neck care. He began working in the orthopedics department at Baylor as an MO in 2017 and became a registrar in orthopedic surgery in 2018. I'm sure we can all agree that we are privileged to have such an experienced surgeon speaking to us tonight about the interesting and ever-evolving world of orthopedic surgery. And so I just want to close out by saying feel free to type your questions during the course of the presentation, and we will be answering a few as well as doing a scrub draw right at the end. And without further ado, Dr. Joda, over to you.
Thank you very much. My fellow South Africans, thank you for having me here this evening, and thank you for joining in. Thank you for a wonderful introduction, Kimone. So unfortunately, as an orthopedic surgery registrar, one of the few things we can't do is open up nightclubs. So I'm not going to be able to do that. But what I can do is invite you into this beautiful world of orthopedic surgery. And let's not waste any more time. Let's get right into it. Right. So firstly, what I want to share with you is the beauty of orthopedic surgery. We don't just save lives on paper. That's not who we are. We actually give people the ability to be alive, the ability to enjoy life. So let me just click through here. So as orthopedic surgeons, we understand physics and physiology. We understand metal, mechanics, and motion. We understand biomaterials and biology. And through this, I've seen elderly patients who are wheelchair bound dancing after their knee replacements. I've seen breadwinners who had devastating injuries and returned to work. I've seen adolescents who could barely breathe with their lungs being squashed, and I've seen them laugh after their scoliosis repairs. Young kids who couldn't walk started to kick soccer balls after treatment with orthopedic surgery. And beyond this, I have to say, who better to give you this talk at the Society's 10-year anniversary? Because 10 years ago, I was a fourth-year medical student at Wits, just like many of you. So in the second part of the talk, I'm going to share with you how I went and the course of my journey going from this, doing this 10 years ago. This is called a Fundelzela, by the way. That's my own invention. And in between, along the road, I did a little bit of this. I did a whole lot of this. And now I'm doing this. So what is this? Earlier this year, a lady came in, a young patient, had this devastating injury to her elbow. You can see it's completely smashed, it's comminuted, it's very badly injured. And I managed to reconstruct it to look like this. This is one of my greatest achievements in medicine so far, but definitely in orthopedics. This is also a young patient. She was just a couple years younger than me, and she had this horrible injury to her distal radius. You can see the multiple fragments, and it's general medicine would say that this patient is going to progress onto wrist stiffness, and she's going to have a non-functional wrist and most likely a very limited functioning hand. But understanding that orthopedic surgery is an art rather than just a science. So I summoned up all my brushes, all my pencils, and with literal blood, sweat, and tears, I managed to do this for her. So you can see she's got a perfectly restored distal radius joint line. And a couple months later, she came in for follow-up, and she has a fully functioning wrist. But listen, don't just take my word for it. Let's ask a couple people. How about we ask Rachel from Friends, or we ask Laura Croft from Tomb Raider? Well, what do these two have in common, right? They married this guy. And it seemed a fairly popular choice. I mean, he was voted sexiest man in the world several times, ahead of guys like George Clooney. So I think we might need to hear what he has to say. What else does he have going for him? He also played the Greek warrior who shares a name with the strongest tendon in the body, Achilles. So now we really need to listen to what this guy's got to say.
I used to work in dangerous places, and people who moved survived, and those who didn't. Movimiento es vida. Movimiento es vida. You have a better chance if you come with us.
How's about that? Movement is life. You have a better chance if you come with us. This, the AO Foundation, so they're a Swiss-based foundation, but really they are the lighthouse in orthopedic fracture management. So their founder was Professor Siegfried Willer, and do you know what he said? He said the same thing. Life is movement, and movement is life. See a common theme here. By the way, for any of you wondering, the AO abbreviation, this is what it stands for. If anyone at the end of the presentation, if you can pronounce this, then I'm going to buy you dinner this weekend and you're going to teach me how to do it because I still haven't learned. So we're talking the 10 years of this surgical society, and I thought that a good place to direct this talk is to talk about trauma. So polytrauma, a patient who's been multiply injured, because this has really developed in orthopedic surgery and in surgery in general over the last 10 years. So where did this renaissance start? It started with this, ATLS. I'm sure some of you may have heard of it, Advanced Trauma Life Support. This movement was actually founded by an orthopedic surgeon. This is Dr. Steiner. He's an orthopedic surgeon in Northern America, and after a devastating accident, a flight accident where he was flying the plane, he identified a need and then developed the system of advanced trauma life support, which is largely accepted by almost every country in the world today. So this began about 80 years ago. And what ATLS over the time, so I beg your pardon, in the 1980s, so about 40 years ago. So what this has shown us is that when do patients die? They die either within the first few minutes, within the first few days, or from days to weeks. And why do they die? The reasons are up on the screen over there. And I'm going to show you how orthopedic surgeons can intervene in preventing the deaths in these instances. And if you look down at the bottom of the screen, we talk about a golden hour. All right? Look at this word, preventable. 60% of deaths can be preventable if treated in this time. So a multiply injured patient comes to you. What do? You freak out, right? Or, well, that's one option. The other option, you go to the basic ATLS principles. Okay, so it starts, you take a brief history and you treat the greatest threats to life first. A, B, C, D, E, right? Primary school kids know this, okay? Okay, maybe I might have caught on to it a bit lower than my classmates, but everybody knows the alphabet. So you stay calm, you recite the alphabet. Airway, look at this, cervical spine control. Okay, orthopedic surgery. Then we move on to here, circulation. So hemorrhage control and resuscitation. Pelvic and long bone fractures can be life-threatening, orthopedic surgery again. Neurogenic shock, so spine injuries associated with systemic shock, orthopedic surgery. So you can see the critical role that orthopedic surgeons play in managing and preventing the loss of life. So then we go on to a secondary survey. So on the secondary survey, you do a physical exam, you update your history, and you obtain other imaging studies. So you find more orthopedic injuries. You then do a tertiary survey after you've managed the injuries found on the secondary survey. Your tertiary survey is a repeat physical exam, more imaging. And if you do this correctly, you decrease the chances of missed orthopedic injuries. And orthopedic injuries can frequently be missed because you can imagine if a guy comes in unconscious, he's on death's door, and he's got a broken ankle, he's not going to tell you, doc, my ankle is sore. So injuries can be easily missed in polytrauma patients, and specifically orthopedic injuries. And that's why following the correct steps of ATLS go hand in hand with the best orthopedic management that you can provide. So I told you that ATLS kind of started around the 1980s and has taken wind since then. But in the last 10 years, and this is why it's so pertinent to the talk today, this concept of damage control has really taken off. So what is damage control? It was taken from the army. So basically it means you are up the creek without a pedal. You now need to salvage what you can. So orthopedic surgery has really refined this concept of damage control orthopedics. And the concept has carried through to all surgical disciplines, through general surgery, trauma surgery. Everyone is kind of practicing this now. So essentially what this tells us is, so if you have a completely stable patient, you can go ahead, you can fix their fractures, you can give them the early total care. So you give them the definitive management, what they're going to need right from the get-go. But then there's this group of patients, specifically these ones, unstable and in extremis. So what about them? So they've had a massive inflammatory response to the initial trauma they had. They got badly injured and they mounted a big response. So if you then take them to theater, you drop their blood pressures with the anesthetic. 2, you then cause more blood loss. And most importantly, you cause a second insult that wants to propagate another inflammatory response. And this was a massive cause of death in patients 10 years ago. But now we've understood that there's a time and a place to operate on patients, and correctly selecting the patients who need surgery and those who don't need surgery right away can save lives. And that's the concept of damage control orthopedics. So this is a very busy slide, but what I want to show you is that it's a very intricate calculation. Okay, so figuring out who should go for theater and who shouldn't, it's a difficult decision to make. And that's why we've got these algorithms in place. So I'm going to give you a case example. This is a young gentleman. He came in post-motor vehicle accident, and the injury that you can see on screen is called a subtrochanteric femur fracture. For those of you who aren't yet familiar, so we're talking about the left femur outlined here. This is the lesser trochanter, and this is the greater trochanter on X-ray. So here you can see the fracture. So it's a comminuted fracture here. So any fracture that falls, so this is your intertrochanteric line. Any fracture that falls within 5 centimeters of this intertrochanteric line is called a subtrochanteric femur fracture. And it's got a lot of clinical significance, but I won't dive into that just now, because the point of this story is that this patient then developed this. So on this X-ray, you can kind of make out that some of the areas, for those of you who aren't yet familiar with X-rays, you can make out some of these areas kind of look like clouds. So we call this a patchy infiltrate. What you're seeing on the right side of the screen is a CT scan. So on the CT scan, you can make out that these white areas over here, so this is pulmonary edema. So that's water in the lungs, right? And that's caused by inflammation, 1, and 2, you can see little dots there that are white. So what's happening? His pulmonary vessels are being blocked, okay? So blood is not going to the alveoli as it should do. This patient ended up needing oxygen, then progressed to needing to be intubated, and he ended up on a ventilator. What caused this? So there's a phenomenon called fat embolism syndrome. What happens is that the hemopoietic tissue, the marrow essentially of the bone, so the really fatty part of the bone, when the cortex is broken, it goes into the bloodstream, either because of increased permeability of the surrounding blood with the inflammation of the blood vessels, or through this inflammatory response, you get coalescence of your lipid molecules. But the end product is that fat is now in the bloodstream, it goes to the blood vessels in the lungs, and it blocks the blood vessels in the lungs. So again, there was this huge fight. It was the middle of the night. This guy had just been intubated, and I felt we needed to fix his fracture to stop this pathological process. It was a fight with trauma surgery and ICU. They felt differently, but we followed the protocol. I went ahead and around midnight, 1 in the morning, fixed this fracture. So this is an intramedullary nail, or quite specifically a cephalomedullary nail, but for the purposes of the younger students in the audience, so basically it's intramedullary because it's within the cortex, so it's in the medulla of the bone, and it's a nail. So you can see it's providing fixation. What is this made of? So it's generally made of titanium, so it's stronger than bone, and it's going to keep the bone well aligned so that the bone can heal. A couple months later, that's exactly what happened. This bone is healed. And this is the gentleman over there. So by following the right steps, we managed to save his life. So this is 6 months after his operation. You can see he's gone back to the gym, he's sculpting his guns. This is before COVID time, so this mask is just more to de-identify him. And this is just another success story from orthopedic surgery and from the development of orthopedic surgery. So I thought a good place to direct this talk is this. So if we select a patient for damage control orthopedics, there's a few things that we address immediately, irrespective of how unwell the patient is. And this is the list of things that we will address. So I thought this is a good list of things that junior doctors or your students, aspiring doctors, this is a good list of things for you guys to know. We do treat a wide variety of emergencies. You know, we've got cement implant syndrome, we've got supracondylar fractures, the list goes on and on. But I think this is a good place to start. So for today's talk, I'm going to talk to you about compartment syndrome, and I'm going to talk to you about open fractures, because these are things that you should always identify. You shouldn't miss them, and you should either be able to manage them or be able to refer them to the appropriate management. So to identify when they need to be referred. So let's go for this one first. Acute compartment syndrome. Right, so what is acute compartment syndrome? So when pressure rises in a confined space, it causes reduced blood flow. So compartment syndrome occurs when the pressure is high enough, so there's elevation in the pressure, and it happens for long enough, for duration, that causes tissue ischemia and necrosis. And I'm going to show you in a moment how this happens. So what happens? We start here. We've got trauma. Something's injured. Let's use the leg for an example. You've got a trauma. Immediately, you get arterial spasm. Then there's arterial spasm, so there's less muscle going to the soft tissues and to the muscles. So the muscle becomes ischemic. When the muscle becomes ischemic, it releases inflammatory mediators, histamines. What does this do? Inflammation causes increased capillary permeability, meaning that fluid can move easier in and out of the vessel. So fluid moves out of the vessel and it increases the pressure even further. This leads to intramuscular edema. So now you've got an edematous muscle and the pressure is really high in there. So it starts to squash your veins because the veins are at a lower pressure than the arteries. So the veins get squashed first. So you start to get the veins, the venous outflow not being quite what it should be. And that leads to increased pressure even again. You can see how the cycle is already starting to feed itself. Eventually the pressure gets so high that it's higher than the pressure in the veins, than in the limbs, and it's even higher than the arteries. So it causes arterial compression. Now there's a complete loss of your autonomic nervous system. So you get no blood flow going to this area, and this then feeds into the cycle. So now the arteries have spasmed and we start the cycle all over again, and it just circles around and around. So those of you who like to nerd out maybe in a bit of physics, I know I'll be honest, and I actually do. So the normal compartment pressure is between 0 to 8 millimeters. So when the intracompartmental pressure rises between 10 and 30, within 10 and 30 of your diastolic blood pressure, then the tissues start to become ischemic. So the reason that we use diastolic blood pressure is because compartment syndrome is essentially a capillary bed pressure. It's a perfusion problem. So we use a formula here. So it's called delta P, delta pressure. So you take your diastolic pressure and you subtract your intracompartmental pressure. So there's two values that we look at. Number one, if the absolute pressure in the compartment is 30 millimeters of mercury or more, or if your delta pressure, so this calculated pressure is within 30 of your diastolic blood pressure, then this patient needs an urgent fasciotomy to prevent that vicious cycle that we just saw. So those of you who are interested, so these are the formulae below. So this is your transmural pressure. So if we've got a blood vessel over here, this is the pressure going across the wall. This is the tension of the capillary. So most of the time in a normal situation, you've got blood at a higher pressure than the surrounding tissues. So it's putting force out onto the vessel wall. And this is the tension, the TC, which is inversely proportional to the radius of the vessel. So what happens with compartment syndrome? You start to get a decreased pressure here and an increased pressure here. So inherently, the vessel now wants to collapse. And if we look at this, LBF is the local blood flow. So this is the same equation that you encountered in high school when you were studying electricity, right? So it's the pressure in the artery minus the pressure in the vein. So the potential difference between 2 points, and then the resistance between the 2 points, which is your vascular resistance. So when the pressure is increased all around, you start to get a decreased flow through there. So your local blood flow essentially gets cut off when this gets high enough. So don't miss it. Compartment syndrome. How are you going to diagnose it? The P's of compartment syndrome is pain, 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 and more pain. Why am I emphasizing pain? Because pain is the earliest and most sensitive sign that you can pick up. So what kind of pain is it? It's pain out of proportional to the injury, and it's pain with passive stretch. So if you have this, you need to have a high index of suspicion of a compartment syndrome. Paresthesia is the next one that's going to come. And the reason for this is because nerve tissue is specifically vulnerable to high pressure. So as the pressure increases, the patient starts to get pins and needles. By the time we start to get this palpable swelling and this paralysis, we're starting to miss the boat. And by the time we get this, so once we get a pale limb with absent pulses, it's fed so much into that cycle that this limb is going to be amputated. So by the time we get here, we've missed the boat. So don't look for these P's of compartment syndrome. This is the important P. Pain, pain, and pain. This is what I want you guys never to miss when you see it. So let's revise some of the anatomy. So the most common place to get a compartment syndrome is in the leg, all right? So the leg has got 4 compartments. It's your anterior, your lateral, and 2 posterior compartments, the superficial and the deep posterior compartments. Okay, so these are the muscles in. So it's easy to remember, those of you who are still doing anatomy, to remember your compartments here and here. So the posterior one, the superficial one, is just your gastrocsoleus complex. To remember to differentiate between the deep posterior and the anterior, it's exactly the same muscles, but the inverse of them. So tib ant, tibialis anterior, tibialis posterior, extensor hallucis longus, flexor hallucis longus, extensor digitorum longus, flexor digitorum longus. And then your lateral compartment is quite easy. It's just your peroneal muscles, peroneus longus and brevis. So what divides them? This here on the right-hand side of your screen, this is how we measure intracompartmental pressure. But I actually put this picture here to show you more clearly how the compartments are divided. So you've got this interosseous membrane, which divides anterior from posterior. Then there's intermuscular septi. So between the lateral and the anterior compartment, and between the superficial and the deep compartments. So these are essentially fibrous tissues that lie between the muscles, and this is what we have to release so that the edema and the pressure can be released. We need to release all of these to release the pressure so that blood flow can return to this area. So I really hope that none of you are ever going to be in the situation where you need to do a fasciotomy unsupervised, and I hope that you're going to learn it in a more productive way, but just so that it's not unfamiliar to you. So to do a fasciotomy in the leg, so like I said, the commonest place where we get a compartment syndrome, you make 2 incisions, so 15 to 18 centimeters long, and you separate them. So just separate them by a flat hand on the patient's skin. That would be about 8 centimeters. So you make an anterior lateral incision, and for that you need to identify and protect your superficial peroneal nerve. And through this anterior lateral incision, you can access your anterior and your lateral compartments, and you release those intermuscular septi that I just showed you. Then you go into the posterior medial incision. So with this one, you release the 2 posterior compartments. The structure at risk to identify is the saphenous vein and nerve. And so what you need to do, you detach the soleal bridge from the back of the tibia to decompress the posterior compartment. And I'm going to show you that here. So here's your soleal bridge on the back of the tibia, and you're going to detach that so you can access this compartment, the posterior deep compartment. These are where you'd make your incisions. So this is medial, this is your medial malleolus, and so this would be your tibial crest. So about 2 centimeters behind that, you make your medial incision, and this is lateral, so you palpate your fibula here, and about 2 centimeters behind that, you make your lateral incision. All right, let's move on to the next one, open fractures. So I know this slide looks pretty gross. It's pretty gory, but you guys are in a surgical society, so I wouldn't be surprised if some of you are actually licking your lips at this. So what is an open fracture? Open fracture is when the bone is broken, there's a fracture, and there's a wound that directly communicates with the outside environment. How do we classify them? So this is the Gastelow-Anderson classification. The first one, type 1 wound. So this is a simplified version, and for your purposes, if you kind of just get familiar with this, that's enough. I'll show you the more detailed one on the next slide, but start with this. Type 1, less than 1 centimeter. Type 3, more than 10 centimeters. So type 2 then is between 1 and 10 centimeters. So we're just looking at the wound size. There are a couple of exceptions. So farm injuries, gunshot injuries, they automatically are Gustello-Anderson 3. All right, so how do we then differentiate? Because type 3 is subdivided into A, B, and C. So to differentiate between A and B, we look at periosteal stripping, and we look at whether the wound can be closed or it needs soft tissue coverage. That differentiates A from B. And C is if there's a vascular injury that requires a repair. Now, Gustello-Anderson classification, when you see the patient in casualty and you see the wound size, you can kind of estimate which one of these it will be, but the definitive classification is made only in theater. So it's an intraoperative examination. Excuse me. So in theater is when we get the final classification. This is the more in-depth classification. And like I said, for your purposes, you don't all need to know this just yet. But if you are looking to remember it, the way that I remember it is I start to go from outside in. So I imagine something hitting the leg from the outside. So it starts with energy, how much energy it is. Then you start with the skin and you look at the wound size. Then you go a little bit further in, underneath the skin is the soft tissue, and you look at the soft tissue damage. Then you look at how much foreign bodies, how much contamination there is. And then we go deeper and we get into the bone, and we look at the fracture pattern and the periosteal stripping. So if you just start from outside in and you follow this, you can remember all the components of this complex classification. These last two is when we start to look at management. So skin coverage, are we able to close the wound? And is there a neurovascular injury that needs repair? So starting from outside in, and we get these first few, and then the last two, we're talking about management. And with them, they go from less severe to more severe as we go from 1 to 3 in all of these, as you can see. So the other thing important on the slide is the antibiotics that you're going to give. So Gustello-Anderson 1 and 2, you're going to give a first-generation cephalosporin. For example, Kevzol, also known as Orthozol by our friendly anesthetists. So if it's a 3, you then want to give Orthozol, so first-generation cephalosporin, plus you want to add something for gram-negative cover, so an aminoglycoside such as gentamicin. If it's a farm injury or if it's a heavily contaminated wound, you want to add a penicillin. The reason being, we need to then also cover for anaerobic organisms, such as Clostridium. Okay, so let's take it back a step. Open fracture comes in, one of those horrible ones like we just saw in the previous slide. What do? You freak out again, right? No, you just follow the steps. So first step, put up an IV line and you give antibiotics. You choose your antibiotics based on the Gustello classification that I've just shown you. And you really want to do this within 3 hours from the time of injury, because the evidence says that any time after 3 hours, the chance of infection really goes up. Plus minus, you might want to give a tetanus toxin depending on how contaminated the wound is. So you want to give a tetanus vaccine. Okay, so you put up the line, you give the antibiotics. Then you remove only large visible debris. So sometimes there's big pieces of tar, there's pieces of plastic or metal, whatever it is in there. If it's large, it's loose, then you take it out. Next step, you immobilize the fracture. So you put up a back slab. The reason for immobilizing a fracture, excuse me, you immobilize a fracture because it then limits the further soft tissue injury, and it decreases the chances of a neurovascular injury by the bone ends moving around. It also helps the patient with pain. So this doesn't just apply for open fractures, it applies for all fractures. You want to immobilize it for those reasons. So once we've done these things, we then, if possible, if within the next 24 hours we can get the patient in theater, this step must be done in theater. But if you're out there, if you're in the sticks, and you're not able to get the patient into theater within 24 hours, then you need to wash the wound out in casualty. So what will you use? You'll use a little bulb syringe, and you want to use low pressure. The reason is that low pressure bulb syringes are cheaper, number one. And number two if you use a pulse lavage or something with high pressure, it actually causes more damage to the soft tissues. What are you going to wash with? So the best thing is actually a castile soap. So this is something based from vegetable fat, and this is superior to normal saline if you have it available. It's not readily available in our state hospitals in SA. And how much are you going to wash it with? So the general rule of thumb, 3 liters for every Gustulo classification that we go up. So a Gustulo 1 is going to get 3 liters, 2 is going to get 6 liters, and a type 3 is going to get 9 liters of wash. And after that, you're going to stage your debridement. You're going to irrigate every 24 to 48 hours as the wound demands. So now I want to talk to you. So that just covered a couple of basic stuff that I think is important for you guys to know. And when you're practicing, it's stuff you shouldn't miss and you should be comfortable with managing. Now we're going to move on. And in honor of this 10-year anniversary, we're going to talk about some advancements in orthopedic surgery. So in orthopedic surgery, we are moving at light speed ahead. Every day, there's some new invention coming out, and these are just some of them. So stem cells, we inject stem cells into patients with delayed unions and non-unions. We now understand this is called the Rankel pathway, the rank ligand pathway. We understand osteoprotegerin. We understand why ladies after going through menopause are breaking their bones. We understand osteoporosis and osteopenia much better. We're able to treat it and direct it, and through this, we're able to prevent fractures. This is a slide demonstrating, so it's a non-biological bioactive substance. So it's something that's not innate in the body, but it works. And this is called bioactive glass. We use it to fill spaces. We use it to cure infections. We understand within a biofilm all the intricate mechanisms of why a biofilm is so resistant to all our treatment modalities. Biofilms, and we understand how they communicate with each other through quorum sensing, and through understanding them, we are able to treat them much better. Guys, we've also perfected time travel in orthopedic surgery. So no, okay, this isn't a time travel capsule. This is a hyperbaric oxygen chamber, and we've seen the uses in, like we've seen in patients who've had compartment syndromes with crush injuries, or with patients with large open wounds, patients with delayed healing of their bones. We've seen hyperbaric oxygen used in sports players to decrease their recovery time. So all of these are huge leaps forward that we experiencing in orthopedic surgery. But today I want to talk to you about just one. So this is called an Elizaroff ring. Okay, so these are the rings and these are rods. So essentially these are threaded, and so when we turn these, the rings move up and down. So if we turn them at different frequencies, we can actually get the ring then to go at an angle, and we can use this for deformity correction. So why is this useful? So I was talking to you guys just now about open fractures. Let's imagine for a second that a patient has undergone a very bad open fracture like the one we just saw, and this patient had a huge bone defect. We can, through this process called distraction osteogenesis, we can actually help the patient to recover that bone loss that's occurred. And while the bone is regrowing and that regenerate is forming, the wound is not under tension because we were able to bring the two ends together. So we're able to close that wound. Even though there was tissue loss, we're able to close the wound and to give it a chance to heal. So why is this important? So this isn't just something theoretical. This is actually a ring fixator that I did just a couple months ago. So this is something that we're actually doing on patients every day. And this is the outcome. So remember this wound we saw just now with this bad bony injury? 10 years ago, guys, this patient would have had an amputation. There was unfortunately no two ways about it. The patient would come in, it's a devastating injury, and we unfortunately have to cut the leg off and do the best we can with rehab. But now orthopedic surgery has advanced so much that, and there's multiple ways to do this. I've just shown you one with the ring fixator, but we've got about 5 different ways that we can salvage this leg. And we can get a guy going from this to going to this. So sure, he's not going to be an Armani model. I'll acknowledge that. He's not going to model underwear somewhere in a catwalk, probably not. But do you know what? He's going to be able to ride a bike. He's going to be able to carry his kids. He's going to be able to take walks in the park. He's going to be able to go to work. He's going to have his life back. And that is the beauty of orthopedic surgery. So if you now have been listening to this talk and you appealed, and I can't see how you could not be, because really this is incredible work that you'll be able to do one day. I'm going to talk to you about the road. How do you become an orthopedic surgeon? This picture, just out of interest, is actually, it's in Jozini. So this is the Jozini Dam over there. This is in northern KwaZulu-Natal. Anytime you get a chance to go, guys, you've got to go out there. This is a picture I took myself. It's one of the most beautiful places in the world. So if you want to become an orthopedic surgeon, the first thing you're going to need a spear and a shield, just like Achilles had. Fortunately for you, I found out that this is available on eBay. No, okay, really. This is your road to orthopedic surgery. You're going to go ahead, you're going to do your internship. Okay. After that, you do your community service. So you may or may not get orthopedic exposure. And guys, it's not the end of the world if you don't, right? Just carry on with the path that you're on, because so now we're talking about medical officer time. Okay, so a medical officer is essentially you kind of like on probation in the department before you become a registrar. So to become a medical officer in the Vert Circuit, so when I talk about the Vert Circuit, I'm talking about the academic hospitals in Johannesburg. To become a medical officer there, you're going to need your primaries, your surgical primaries. That's kind of your admission ticket into the interview. So it doesn't guarantee you the post, but that's what you're going to need if you want to get into the interview. In order to do that, you need to do your basic surgical skills to qualify for your surgical primaries. Okay, and then after that, and just as an aside, guys, if you go from here to here, maybe you get a post in an academic hospital, but maybe you don't. They are hard to come by. There are other options. If you don't manage to get straight in, you can become a medical officer in orthopedics in one of the smaller hospitals. We've got Leratong, we've got Sebokeng, we've got Clarksdorp, we've got Telemoharane. There's a whole lot of options. Or the other option is you can start filling in some of this time, start filling in some of your ICU time as a medical officer. General surgery is very easy to get into now. You can get in post-ComServe, so you can get in and you can do some of your general surgery time. So set yourself up for your later career. Even if you're not able to do this, then you can always come back and you can join this, but you haven't lost any time. So if you want to become a registrar, you go from medical officer to registrar. Your admission ticket is your orthopedic surgery intermediate exams. In order to do that, you need ICU time, you need general surgery time, and you need ATLS. So you need these three things to qualify for your intermediate exam. You get your intermediate exam. Again, it doesn't guarantee you a registrar post, but it will get you into your interviews. Then you want to go from registrar to consultant. All you then need after that, your research project and your final exams, and you are on top of the world. So I said to you, I would share with you my journey. So my journey was slightly different. In between, there was a big hiatus over here between orthopedic medical officer and my community service. The reason being, I was pursuing a job in pediatric surgery. And while doing that, I got recruited for cardiothoracic surgery. So in trying to pursue that, I did my APLS and I did my ACLS. And through that, I did my general surgery and my trauma time. So now there I was, and to get into ped surgery, you need surgical intermediates, so not orthopedic intermediates. So I did my general surgery intermediates, and I did some emergency medicine. And now I decided I was going to join orthopedics. And now I felt like a little bit of a loser because I had spent all this time doing all of this when I felt like maybe I could have just been jumping along here. And guys, the reason that I'm sharing the story with you is because I then went into the registrar interview and everybody had this. And this was the time when posts were being frozen. I don't know if any of you are familiar with the registrar posts being frozen a couple of years back from a government level. And everyone went in with this. But I went in not just with ATLS, I went in with ATLS, APLS, and ACLS. I didn't go in with one set of intermediates, I went in with two. I didn't go in with 3 months and 3 months of ICU and trauma. I went in with years of experience. And so the first post that became available, they gave to me. And the reason that I want to share the story with you guys is because I want to tell you, guys, if you don't go from here to here, first chance, don't become despondent. Don't join and become stressed out and feel the anxiety of this rat race around you. Everybody walks their own journey. And in the end, your journey, the beauty of your journey is in the uniqueness of your journey. And when you compare yourself to other people, that's how you breed unhappiness in yourself. So what I want to tell you is just to walk your own journey and to enjoy your journey. And in the end, you'll get to the destination that you were meant to get to, and you'll be a much better person and a much better doctor for it. So don't freak out, don't stress out, just enjoy the moment that you're in, and everything will be fine for all of you, I promise. So I want to tell you just a little bit more about orthopedic surgery, specifically at Wits. So you do need Momir, Thor's hammer, and you do need a steamy red cape. But so generally, this is how the circuit's going to run. So if you get into the Vert Circuit for orthopedic surgery, you in for, call it 5 years of registrar time. It's 4 to 5, but they are trying to punt it becoming 5. You'll rotate through those 3 academic hospitals I mentioned just now. You'll also do a 6-month stint at one of the smallest, so Sebokeng, Telemokhrane, or Klerksdorp Hospital. So it's an outreach program with the idea to try and keep the academia and the level of patient care up by rotating registrars through slightly smaller hospitals. So you're going to do that for 6 months. Then within your 5 years, 18 months of it is directed to orthopedic trauma, so fracture management. The rest of the time, you're going to do 6-month rotations, and you can see the diversity in orthopedic surgery. Guys, when I say it's beautiful from so many different ways. And one of the ways is that it is so diverse that everybody finds a home. Everybody finds something that appeals to them. We've got arthroplasty, which is joint replacements. We've got spine surgery. We've got sports. We've got hand surgery, which is very intricate microsurgery. We've got pediatrics. So we're one of the few disciplines that manages both children and adults. We've got foot and ankle, and we've got tumor and infections. So these are the units that kind of run in most of the hospitals. Specifically at Baylor has got all of them, but some of them aren't present, for example, in Helen Joseph Hospital. But these are the units, and this is the exposure that you're going to get if you join the Vert Circuit in your training. All right, guys, so time for questions. I'm actually going to preempt you guys because I know what your first question is going to be. And I'm going to start sharing my video again with you guys. So your first question, I know everybody's wondering, we're here, we on the Zoom chat, and everybody's wondering if I'm wearing pants. And so I have to answer, yes, I am. In fact, I've honored you guys. I'm wearing pants. So, all right, so I just wanted to get that one out the way so you know that when you're talking to me, I'm fully clothed. And after that, I'm going to click on this Q&A. All right, so the first question I've got here, to what extent is orthopedic surgery creative in applying treatments in the golden hour? What happens if you are blank on how to treat the ABCDE? Okay, so to answer your question, like I said to you, so orthopedic surgery is an art, okay? Orthopedic surgery, like I had shown you some of the cases that I did, like specifically that distal radius. That distal radius came from the theory of a couple of things I had found and the application and understanding of orthopedic surgery. So if you show the same injury to 10 different orthopedic surgeons, the famous line is that you'll get 10 different management strategies. So we are extremely creative with how we manage things. There's no black and white. There's no single best answer. It's all just understanding principles. That's the beauty of orthopedic surgery. And more specifically, to talk about the golden hour and the ABCDE. So these are, the ABCDE is more about life-threatening injuries. So if let's use the example of an airway. If an airway is compromised, you do need to secure the airway. So there's not a lot of creativity in that. But if perhaps you're on the side of the road, So I've seen people who have secured airways. It doesn't work well, and I'm not condoning it, but literally with large plastic tubes or with pins, they did a little crike, and you can do that. You can splint fractures with branches from trees, with cutout cardboard boxes that you've seen a lot, I'm sure. You can help immobilize or make an arm sling out of a scarf. So you can get quite creative with that. So I hope that's answered your question. There's some things where you can apply creativity, and other things, unfortunately, you do need specialized equipment to try and sort it out. All right, so moving on to the next one. Thanks for a great lecture. You're very welcome. Thank you for having me, guys. Advice on how to improve chances of getting a reg post while still in med school. So I would say that probably the only stuff that you can do is, for now, you can do your basic surgical skills while you're still in medical school. And there's also a basic orthopedic skills that you can do, and that should help you in the latter run. But if you love it, and if you're really passionate about it, my personal advice to you would be to enjoy your medical school time, right? Like you still are a human being, and you've got a lot to offer this world, and just enjoy the moment that you're in. Your chance to build up your CV as a medical officer will come when you're a medical officer. Your chance to be a registrar will come when you're a registrar. So yes, apart from that, I can't think of anything offhand that could help you, apart from the surgical skills and the orthopedic skills while you're a student. But definitely, once you get into your community service or your medical officer year, there's a lot more that you can do to strengthen your chances. Okay, the next one. Many orthopedic patients are high risk of DVT. At what point do you initiate warfarin / low molecular weight heparin? Okay, so we're talking about anticoagulation. So let's start with this. We're going to divide them into trauma patients and elective patients, right? So emergency versus elective patients. So an emergency patient, the one component of being multiply injured is that you get a coagulopathy. The coagulopathy comes from acidosis, one, and it comes from a platelet, functional platelet, so abnormality, as well as a quantitative platelet. So it's quantitative and qualitative platelet abnormalities. So you've got a coagulopathic patient. Also, they may have bled out a lot of their clotting factors. So you don't want to put that patient immediately on anticoagulation. And the other thing is that you're planning surgery for them. Okay, so you want to hold off your anticoagulation until after your surgical management, so that the patient doesn't bleed out and have uncontrollable bleeding during surgery. So for that specific patient, once you've got a clear idea about when you're taking them to theater, and once their coagulopathy has resolved, that's when we're going to start to anticoagulate them. Then we go on to the next one. So let's talk more about elective patients. So if a patient comes in, for example, for a hip replacement for arthritis, we actually give them anticoagulation to prevent DVTs. Because like you said, they are high risk of DVTs because they're patients who aren't moving around. So we give them actually anticoagulation, and we start with the low molecular weight heparin, which is Clexane. Those of you who are not familiar, so Clexane is essentially, it's an indirect 10A inhibitor, and it's given subcutaneously. And so the important thing of why we use Clexane specifically is because its half-life is only 12 hours, right? So we can, the night before surgery or the day before surgery, we stop the Clexane, and then we can continue it again after surgery. So after surgery, we begin it as early as day 1 post-surgery, provided that we've got good hemostasis in theater. Initiating on warfarin. So warfarin we only do for long-term. So even with a hip replacement, when they require up to 1 month of anticoagulation post-hip replacement, we actually teach them to inject themselves with Clexane. And the reason being is that warfarin, you know, can be dangerous. You can get over-warfarinized, and you can continuously have to check the warfarin levels to make sure that that's not happening. So it becomes a logistical dilemma. But if a patient has an established DVT, and now we're talking about 6 months of treatment or pulmonary embolism, that's when we initiate the patient on warfarin. And the next one, do you work closely with engineers to design and produce custom, scroll down, custom implantable mechanical devices or standard set of implants that you have to make work as best you can? Okay, so the first answer is that most implants are largely they come as they come. And for example, if it's a plate, you do have to bend it if the patient's anatomy is slightly different to the anatomy of the plate. So you do have to manipulate a little bit and you do have to make it work. But that being said, there is a concept of 3D printing. So where joint replacements are actually 3D printed for specific patients. But the kind of spectrum in between that comes down to proper planning of surgery. So you need to say, what am I trying to achieve and what will I require to achieve it? And in that way, because the devices available to us are so vast that if we plan properly, we can then order the device that we need. And just as an example of that proper planning, we are mention hip replacement surgery. So we do something called templating, where we measure the outcome of what we want and we measure the patient's current anatomy and we order the exact sizes that we need. Okay, I've got a question from a good friend of mine. That was my question, taps and pants. They're usually tight. Yes, it's true. I haven't always had a good relationship with pants when I was a student, but fortunately now society has suggested to me that I do need to always wear pants. While you're in this journey, are you able to build a life outside of work and the studies, like starting a family, settling down? Guys, so thank you for this question. Thank you for all the questions. They were very insightful, but this specific one is, thank you for this specific question. Orthopedic surgery, it's intensive. Specifically your registrar time, it is difficult, but one of the advantages and one of the appealing things to many people is that compared to trauma surgery or general surgery or other types of surgical disciplines, it does afford you a lifestyle. And the reason that I'm so happy about this question is because we can become a bit infatuated with our careers and with our career progression. And we need to also remember that we are human beings. We need to remember that as human beings, and I mean the WHO even describes health as being emotional, mental, physical, and if you are spiritual, then spiritual health as well. So health is really, it's a wholesome concept because we are wholesome beings. So I'm very glad that you asked that question. And I hope that no one here loses cognizance of the fact that it's okay to be a human being. And so yes, as humans, we want to start families, and I would say yes, as in orthopedic surgery, there is room to start families and to have a life outside of work. Myself personally, so just this year during lockdown, I've learned to play guitar. I've joined parkour. I don't know if any of you know it. I like to stay active at the gym. I have awesome friends like this one who's just posed me that weird question. And so we do have social lives outside of work. All right, next question. All cranial fractures in the area of neurosurgeons or head and neck surgeons. Okay, so I think essentially, so you're trying to ask facial and cranial fractures. So essentially, facial fractures get managed by maxillofacial surgery, and all cranial fractures, specifically those associated with traumatic brain injuries, those are managed by neurosurgery. So orthopedic surgery, we very rarely, actually, we operate on the entire body from the neck down, right up to the small toes. And one of the areas that we don't operate on is actually the head. The only exception of that is cone calipers. So it's a device that we use to apply traction when a patient has a cervical spine fracture. We apply calipers, so a form of traction onto the head, and that's pretty much the only cranial or facial surgery that we do. Hi, Doc. Is there a physical challenge for ladies wishing to pursue orthos? thank you so much for this question. So orthopedic surgery is about understanding of physics and about applying, it's about working smart rather than working hard. So there are times, there's bigger patients and there is a lot of muscle force applied across joints and that you'll have to overcome. But no, there are incredible female orthopedic surgeons out there, and they all aren't Olympic weightlifters. The old stereotype, we actually are trying to banish it in the department, that old stereotype of this big muscular jock who does orthopedic surgery. Not that you're not welcome. If you are a big muscular jock, you're more than welcome to join. But what I'm saying is that you don't have to be that way. So there's very petite ladies who come in and they manage to do it just fine. And they are as good, if not better, than any of the guys around. And I'm talking about consultants as well as registrars in the program right now. So if you're passionate about it, don't let your size or your gender deter you in any way. Thanks for the honesty. You're more than welcome. With me, you'll find you're going to get an open book. I'm sorry. It is what it is. To what extent do orthopedic surgeons work with neurosurgeons on the spine? Or is it just for? So every hospital actually has its own kind of red tape around this. So when a patient comes in with a spine injury, at Barra, the answer is that if the patient has neurology, it will go to neurosurgery. If the patient doesn't have neurology but has just a bony or ligamentous injury, that it will come to orthopedics. But that line is not hard and fast, and it exists only as far as the institution. So when you're out there and you've got your own practice, the short answer is that a patient who needs spine surgery can be operated on by either a neurosurgeon or an orthopedic surgeon. I will say that because we are more experienced with the tools and with the biomaterials that we use, so orthopedic surgeons then tend to manage more of the bony injuries, but there's definitely no distinct line when it comes to spine surgery. The next question, what's your favorite part in your day as an ortho? My favorite part of the day. My favorite part of the day is when I get to work and I meet the incredible people around me, because it is a department filled with really awesome people, and we have a fantastic working vibe amongst us, and I love what I do. I love orthopedic surgery. I love the operations. I love the theory. And so the entire day is my favorite part of the day. And what is the longest surgery you've been part of? So the longest surgery I've been part of, a scoliosis repair on a young child. So that's when the spine is kind of S-shaped and it's bent over. That's the kyphosis. The surgeries can take, the one that I was specifically involved in took 8 hours. So that was the longest one I was part of. The longest one I've done myself was at Sebokeng Hospital, and it was an ankle fracture that was very old and was fractured in multiple places and needed bone grafting. And that took me 6.5 hours. So that's it. All right, I think that is all of the questions. One's just popped up here. Sorry, say that again.
I was about to cut it off, but I think we'll have this as the last.
As the last question.
Yeah.
Okay, cool. To what extent would a podiatrist and an orthopedic surgeon interact in regards to the medical field and patient management? Also, do you have any suggestions for someone looking to transition from podiatry to orthopedic lower limb surgery upon qualification of the degree? So orthopedic surgery actually works, it's one of the things, we very multidisciplinary. So we work hand in hand with podiatry, with occupational therapy, with physiotherapy. We work together with the orthopedic workshop. So we definitely work hand in hand together with podiatry. And in terms of becoming an orthopedic lower limb surgeon from becoming a podiatrist, well, I'd say you'd still have to follow the same algorithm that I showed earlier of, kind of going through your medical degree and following the rest of it. you definitely will be in a strong position because you'll understand gait, you'll understand walking, and so it will definitely be to your benefit in the future. But I don't think that it lends you any kind of shortcuts into the field. And I think that's about all the questions that we've got up here.
So before I hand over to Priyanka for the thank you, I just wanted to announce the winners of our scrubs through a completely randomized process. The two winners are Giselle De Cavallo and Joshua Arenson. Both names will be posted on Instagram and they'll be noted as well, just so that when we eventually return to campus, you guys can collect your scrub. And, you know, just from my side, I have to say that, you know, we really appreciated everything that you showed us today, Dr. Joda. You taught us so much, and thank you for being willing to do it. And, you know, the banter between orthopedic surgery is power. I have to shout out Dr. Ngema, since she was our great debate participant for orthos. And, you know, you guys really do have such a cool team dynamic. But over to Priyanka, and thank you again.
Thank you.
Wow, I know I speak for all of us when I say that I'm so absolutely inspired, not only by the field of orthopedic surgery, but by the passion that you emanate when you speak about your occupation, really, which I think is so important in any medical career for that matter. In closing, a huge thank you to all our viewers who've joined us today to learn about the absolutely miraculous field of orthopedic surgery, and to the entire society for helping organize an event of this magnitude, which we all know is never easy given the circumstances, but which I'm sure we can all agree has been done absolute justice to by Dr. Joda's absolutely enjoyable presentation. In closing, on behalf of the Vert Surgical Society and all the viewers who have joined us, I would like to extend my sincerest gratitude to you, Dr. Joda, for taking time out of your very busy schedule to expand our knowledge on orthopedic surgery, and for doing so in such a jovial, lively manner and inspiring us to the lengths that I know you have. A huge thank you again, and we hope to collab with you in the near future.
Priyanka and the society and all the viewers, it was absolutely my pleasure. Thank you so much for having me. And I really hope that you do leave here inspired, because that was the purpose of all of this.
Absolutely, you've done exactly that. Thank you, Doc. And thanks to everyone.
Thank you.